Hello everyone, and thank you very much for joining us today. I'm Deborah Garlick from Henpicked, Menopause in the Workplace, and author of the book, Menopause, The Change for the Better. Today's session's all about endometriosis and the menopause, and this is such a popular subject, something that we get questions about all the time. And I'm delighted to welcome Dr. Karen Morton today, who is a consultant obstetrician and gynaecologist, and also the medical director of Dr. Morton's. Now she's fresh from the delivery suite today, so I think, Karen, if you can join us, and congratulations on just delivering a baby this morning. It's great that you've been able to join us today. So endometriosis and menopause. But first of all, can we, because I know we talked about this a lot beforehand, can you tell me what endometriosis actually is?
Yes. Well, first of all, thank you for asking me, Deborah. It's lovely to be with you again. So endometriosis, the lining of the uterus, the correct name for the lining of the uterus is the endometrium. So endometriosis is a condition where there is endometrium in the wrong place, outside the uterus. In truth, bless you, in truth, there is also a permutation around that whereby you can have endometrium in the wall of the uterus. And if that is the case, that has another special name called adenomyosis. So that's an additional name that women may well have heard of. So endometrium responds to the cyclical hormones from the ovaries, estrogen telling the endometrium to grow, and progesterone telling the endometrium to stop growing after ovulation and become nice and thick and juicy and prepare for a pregnancy. Of course, if a pregnancy doesn't occur, then the progesterone level falls and the lining of the uterus, the endometrium, falls away as a period. Now, the lining of the womb itself is just a bit of a flimsy nothingness, really, and most of the blood you see is blood that is coming from the raw blood vessels in the wall of the uterus. So if your uterus is doing that, if the endometrium in the uterus is doing that, those growth and bleeding cycles are happening everywhere else in the body where there is endometrium in the wrong place. And blood is a very, very irritant substance in the tummy, to the lining of the tummy, the peritoneum, and it causes inflammation and scarring and sticking. If you get endometriosis on an ovary, the blood, instead of just dispersing, collects together, and each time a period happens, a little area on the ovary will grow and grow and grow, and altered blood, as you will be aware, at the end of a period is brown, and so it produces what are called chocolate cysts. It produces cysts on the ovary that contain what looks like chocolate sauce, and they can be huge. I'm going to tell a little bit more about endometriosis because it's important that women know that we really don't know why it happens. Was the woman born with these spots of endometrium in the wrong place? Embryology, after all, is a fascinating thing, that all the bits are in the right place. Or is it that there is some retrograde menstruation? Is it that during a period, cells, instead of just coming out through the cervix, go along the tubes and then grip on and develop a life of their own? They remain living cells that then respond. Probably it's a combination of the two.
Oh, so that's really interesting. So, and when the endometrium is in the womb, then that's absolutely fine. That's where it's supposed to be. But it's that leaking out and going to places where it shouldn't be,
yes,
that causes all of the problem. And that's on a monthly basis. So how is that diagnosed? How do you know you've got endometriosis?
It's a good question. There are some classical features to the sort of pain that comes with endometriosis. A lot of women with heavy periods will have pain when the bleeding is heavy. And if you imagine it as a clot developing inside the uterus, and then the uterus having to go to push out a clot through the narrow channel of the cervix. But that's not the sort of pain that women get with endometriosis. It's not because of heaviness. And often the pain will be at its worst in the few days leading up to the period. It can very, very commonly cause painful sex because the scarring, the sort of inflammation and scarring that I've described, can mean that instead of the uterus and ovaries moving about during the sort of joggling of penetrative sex, they're stuck, they can't move, and that makes sex very painful. Often you can get deposits of endometriosis in the space between the vagina and the rectum, the back passage. They're very close together. And that can lead to terrible pain when you do a poo during a period. So there are those sorts of classical symptoms, but of course not everybody has classical symptoms, but they would be the distinguishing features. Pain leading up to the period being the worst, terrible painful sex, and pain when doing a poo.
So if you've got endometriosis, then how is it that pain, those triggers that you would say, go to your doctor and it be diagnosed? Is it easy to diagnose? How do you diagnose it?
Well, if you do have painful periods, you should go to your doctor for sure. And if you have, your doctor will probably suggest you have a scan. And the scan will only be abnormal if there are chocolate cysts on the ovaries. An ultrasound scan can only elucidate the nature of a measurable thing, something that measures 3 centimeters or 4 centimeters. It's no good at looking at spots. So if the scan is normal, it doesn't mean that you definitely haven't got endometriosis. You might have spots of endometriosis. And the only way of finding that is to have a telescope put into your tummy, which would be called a laparoscopy. So under a general anesthetic, an incision is made just under the tummy button and a telescope is put in. Now, in many ways, if there aren't measurable things on the ovaries, you might well choose to have the treatment for endometriosis rather than have an operation which has risk. So the best way of treating endometriosis is always to stop the periods. Now, periods can be stopped in physiological ways, in other words, being pregnant or having a baby or breastfeeding, or they can be stopped with hormonal methods, or even anti-hormonal methods that switch off the ovaries and actually temporarily make a woman menopausal, interestingly. Right. But probably the simplest way of stopping the periods and the most reliable will either be to take a combined oral contraceptive back to back, in other words, not having a break between packs, or probably even better, to go on to a progesterone-only pill, for which when women take a progesterone-only pill, over 80% of women by 3 months will have no periods. Okay. Now, others of your listeners may think, well, what about a Mirena coil? Well, I love the Mirena coil. It's fantastically good as a treatment for heavy periods. But of course, it releases the hormone that it's releasing into the uterus. Yes. It can be good for that condition I mentioned, adenomyosis, which is within the wall of the uterus. And so the hormones of the Mirena can get into the wall of the uterus, but it's not designed as a hormonal treatment for outside the uterus. So it may be that it will stop visible bleeding, but it may not stop cyclical pain.
Okay, so in stopping the periods, because you described that it's the cycle of hormones and the estrogen building up the endometriosis or endometrium, and then the progesterone. And so what you're saying is when you stop that cycle things should be more comfortable or manageable for the individual.
Yes.
Which brings me on to the question of menopause. Very often people will say, will this get better? Will my endometriosis get better or worse as a result of my period stopping altogether? Now, it seems like you're going to say yes, but I'll leave that to you to say, actually then, does endometriosis get better when a woman enters the menopause?
Yes, it certainly does, as long as she isn't taking any hormone replacement therapy.
Right, so, okay. The perimenopause is the phase then where hormones can go bonkers.
Yes.
So does that get, is that likely to trigger more pain, less pain?
It's going to be just the same. It's not going to be any different. So every time she has a period, the woman has a period, there'll be some internal bleeding. So there isn't any logic for thinking that the perimenopause, when a woman is having maybe irregular but still having periods, that it's going to be any different compared with if she was 21 years old and had endometriosis.
Right.
Now, of course, a lot of women, in fact, I want to say a little bit more about the severity of endometriosis that women experience. It is even allocated a staging, stage 1, 2, 3, and 4. So I might put a telescope into a woman's abdomen and see that she has everything completely stuck together. She's got big chocolate cysts, the bowel is stuck, everything is really, really stuck together. And it can even penetrate into deeper tissues, causing the tubes that connect the kidneys down to the bladder, the ureters, to be obstructed, to be blocked by the scarring over the surface. So women with very severe endometriosis may well have their uterus and ovaries removed. They may well come to a surgical menopause, because if they've got very severe disease, just removing the uterus will not cure the disease, because their ovaries will continue to cycle.
Right, okay. So there's the natural, which, as you say, during the perimenopause, it would be the same, and ideally when periods stop, maybe will reduce,
it will
stop. If it's surgical, if it's got that bad, and the individual would go through menopause from the surgical approach. Okay, so understanding that, and I can see there's lots of questions coming in. One of the things that you did mention there then was that one of the treatments that many of us use for menopause is HRT. How does that affect endometriosis?
Well, if you're taking a cyclical HRT because you are not yet a year after your last period, so you're not at menopause. So if you tried to take a no bleed regime, your uterus would get in a muddle. So you would be expected to take a cyclical regime. In which case, if your endometriosis is troublesome, it's likely to continue to be a bit troublesome.
Right.
It may be that you will be one of the, it is complicated, I'm sorry.
I know, I was actually just thinking that. I was just thinking it kind of, if you choose to take HRT because of the benefits of it managing your other symptoms, but it makes your endometriosis continue or feel worse.
Well, it will perpetuate it. It won't make it feel worse, but it will perpetuate it.
So but of course, one of the considerations in deciding whether to take HRT is actually then, can I manage my symptoms without HRT because I don't get the endometriosis?
Yes, but it may be that woman would take a progesterone-only pill, like many women will for contraception, which will keep endometrium quiet. She could start hormone replacement therapy with taking a progesterone-only pill, and that would be the right thing for her. Right. Now, of course, if you've had a surgical menopause, say at 40, you've had the uterus and ovaries removed because of really severe disease, you could never say to a woman, as a surgeon, I have removed every spot of endometriosis. Of course, a 40-year-old woman absolutely needs hormone replacement therapy. But unlike women who come to menopause without their uterus for other reasons, for prolapse or for fibroids or whatever, a woman who's had her uterus removed for severe widespread endometriosis, she is not suited to taking just estrogen.
Right.
Because the remaining spots of endometriosis, which there will definitely be, you could never say you've removed every spot, would be stimulated by the estrogen alone and could become abnormal to the point of endometrial cancer within endometriosis.
Wow. Now this it really helps me understand why this is such a difficult condition, and difficult for people to make informed choice, because everything that you just said makes this really complicated for somebody that is struggling with endometriosis now and potentially facing menopause and thinking, well, what's right for me? Is it going to get better? Is it going to get worse? How do I continue to manage the condition even though my periods have actually stopped? And if you're looking at symptoms,
when periods have completely stopped, so there is no innate ovarian activity, then those women will be perfectly well suited to a continuous combined regime.
Right.
And these days, of course, that could be either a tablet with the same estrogen and progestogen in every tablet. It could be the new preparation Bijuve, which has got both estrogen and natural progesterone in every capsule. Okay. Or it could be a component HRT in the form of estrogen through the skin and natural progesterone by mouth.
Okay, so Bijuve, that's the new one by Theramex, isn't it?
It is, yes.
And that one is new, isn't it? That one's completely
It is very new. It was launched in November. I think it's a very exciting product. I see a lot of women who develop erratic bleeding, obviously women who've still got their uterus, erratic bleeding on component HRT. They run out of one and not the other, or they forget to take one and not the other, or whatever it is. It's a bit more complex. And so if a woman does not have risk factors for deep vein thrombosis, clots in the legs, then really she can take an oral preparation. And having it, this is the first time that natural progesterone and natural estrogen are in a single capsule. So I think it will be a bit of a game changer, to be honest.
I can imagine me after this, Dr. Morton, getting in touch with you through Dr. Morton's and saying, I'd really like to try that one. Because I know, I use the gel and the tablets, and yeah, you're right, actually. It is going and getting two preparations all the time and making sure I'm not running out of one or the other. But particularly for those with endometriosis, it sounds like it's an absolute ideal. Now I can see that we have a lot of questions coming in, and absolutely agree with you around informed choice here. So we will make sure that we put links in to reputable resources around endometriosis after this, because I know you're as passionate as we are about informed choice, and this sounds like an area where people need lots of information to balance up the risk and benefits for them. So delighted to be joined by Sally Leach, the Training Director of Henpicked Menopause in the Workplace. And I could see how many questions we were getting there, Sally. So what were the key themes?
Yeah, we're getting lots through some of them are quite similar themes, but in particular, we've got an example. This actually came through prior to the session and summarizes a lot of what people are struggling with. Somebody who's saying that she's seeing both a gynaecologist about endometriosis and a GP about menopause. And she said the GP has prescribed HRT and to help manage menopause symptoms, but the gynecologist is saying because she's still perimenopausal, not gone the 12 months without. So she was recommended to have a combined HRT that produce then that monthly bleed, and so obviously that is exacerbating. So she's kind of feels like she's stuck between the two, as she doesn't know which advice to be taking as to whether she should be trying HRT because she really wants to try and get on top of symptoms, or whether she should be focusing on the not taking HRT because of the impact from an endometriosis point of view.
Of course, it's always very difficult to answer very specific questions. So I don't know what, there's endometriosis and endometriosis. There are those women with stage 3 and 4 disease where it's been a really major thing. And then there are other women who've just got a few spots and they would be more than adequately controlled with a progesterone only pill.
Okay.
So it would be, I would encourage the questioner to think there will be a solution, and it will be some fine tuning. It might involve, it might be a bit complicated. She might not manage with one preparation.
Yeah.
But I'm sure it's possible. If she's got bad symptoms, she definitely needs to find a gynecologist who has a particular menopause specialist interest as well.
Yeah, brilliant. And someone's asking the difference between endometriosis and adenomyosis. What's the kind of difference in terms of understanding what's someone's experiencing and how the two may differ in terms of what someone could be experiencing from a symptoms point of view?
Yes, well, very similar symptoms, really. Adenomyosis, as I mentioned, is womb lining, endometrium, in the wall of the uterus, so that you get bleeding in the wall of the uterus, which is intensely painful. But also it tends to make the uterus a bit bulkier, a little bit bigger. So women with adenomyosis will tend to have heavier periods as well, because the surface area of the lining of the womb is expanded. But I would encourage women with adenomyosis to have a Mirena.
Okay, because it's locally.
Yes, it's locally effective.
Okay, and then someone's asked if there are any longer term considerations for postmenopausal women who have endometriosis. So she's postmenopausal on a combined HRT. Just any considerations people need to think about once they're into that postmenopause journey?
No, once she's postmenopausal, I'm sorry about the emergency buzzer going on the delivery suite, but it doesn't matter. I don't need to run. No, they will be suited to a continuous combined regime just the same as anybody else, because it will just be completely quiet. There's no cyclical activity. I don't know if that's going to go on. You'll have to ignore it, girls.
No problem at all.
Stopped. So they should have no difficulty once they're completely postmenopausal.
Okay.
It's that difficult time leading up to being completely postmenopausal. In other words, no residual ovarian activity, no flutters of activity that could just get endometrium, wherever it is, into a muddle.
Yeah. And then it kind of goes on to, so it's somebody who's on the progesterone only pill for endometriosis, not had periods since 2017. Menopause is horrendous and has been told she shouldn't be on HRT because of the risk of starting the challenges around endometriosis again. Just any thoughts around that? Yes,
a very straightforward thought. It's completely and utterly wrong. There is no reason at all why the lady concerned cannot have estrogen replacement.
Brilliant. So some really,
it's a bit like, you know, Sally, it's not so different to the number of women I hear who are told they can't have HRT because they have migraine. And that, of course, also is rubbish.
Yeah, absolutely. And I think this is the hard bit. And so many people are just saying, thank you so much, that this is amazing getting this information, because I think this is really hard for people to find out this type of information. Someone's talking about they've had a bilateral oophorectomy for extreme widespread endometriosis, now on HRT. So the Sodrina gel, due to having also had DVT. So just wondering, she's asking whether she should be thinking about a combined dose, or is you know, what would be, I know it's obviously very specific to that individual, but just if somebody has had that the treatment, is it okay just having that estrogen replacement?
No, it's not. But your question hasn't told me whether the lady had her uterus removed at the same time. I expect that she has, yeah. But it's exactly that case I mentioned earlier, the very severe endometriosis. Your ovaries removed at young age, of course, needs estrogen for health, but you cannot say you have removed all the spots of endometriosis. You can't.
Yeah. And I think that's coming through in the questions. Sorry, Deborah.
Just ask one question, because I know I'm a member of Dr. Morton's, and we don't do promotion and advertising through Henpicked, but do Dr. Morton's cover endometriosis? Because I have, I'm on your monthly, is it 10, 12 pounds a month subscription? Yes. So I
pounds a month. It's pretty inexpensive, isn't it? I always think that. But anyway, yes, of course. I mean, obviously we can't, when we're talking to a lady or looking at her on a video, we can't make that specific diagnosis, but we can, through taking a really careful history, we can decide whether this lady needs to go with the right words. You often talk about having a good conversation with your GP, Deborah. I've heard you say it so many times, and it's such a really good thing to be able to go and say, actually, I know that I've got this symptom, and this symptom, and therefore I know that there is a strong possibility I have endometriosis, and I need therefore to be referred to the hospital, please.
And that's what I'm thinking, because you know, we've always got to think about everybody's budget here, but all of the time you're thinking about this, my brain always goes off into decision trees. If you've got this, if you've got this, if you've got this, if you've got this. Now, if my brain's going, I can't work out where that next branch is.
Yes.
I can understand how people might get stuck in the system and of the, is it endometriosis, is it this, what's the right thing to do? And of course, informed choice is always about being really clear what's happening for you and your options, and making an individualized choice based on your balance of benefits and risks and your personal preference. So that's why I was asking if you cover endometriosis, because of course you can't do a remote.
Definitely do. And you know, a lot of ladies will ring us up through our helpline, and they'll say they've got these ghastly, painful periods at whatever stage of life. They could be perimenopausal or 17, and they've had a scan which is normal, and that's not surprising because they could just be spots. Okay, and I will say that, of course, the only way to be sure is to put a telescope in your tummy, but that has risk and discomfort. And so you could make a jolly good case for going onto a progesterone-only pill, do that for, say, 6 months, and it may well stop your periods completely, stop the pain completely, and you've avoided needing to take that risk. Now, some women have a sort of really innate need to know, and that's okay. I can accept that because it's their decision. But I will, as a surgeon who I don't like taking risks at all. So I will encourage women, unless they really feel that they've definitely got a need to know, to take the treatment, because it would be the treatment anyway. It's not as if the operation would solve the problem. If there are only spots, it's pointless thinking that you can laser or cauterize spots, because you can only cauterize the ones you can see. You can't cauterize the ones you can't see. So the treatment would be the same. So try and avoid surgical risk. All people, women, we should all avoid surgical risk if we can.
Yeah, I've just got one final question. That's just if somebody's has blood clotting risk and they're potentially suspected of endometriosis. Again, in that situation, would the progesterone-only pill be the best approach for them?
Yes, it's only synthetic estrogen that has a blood clotting risk.
Yeah.
Natural estrogen taken by mouth as an HRT preparation does, of course, go into your liver. Everything you absorb from your gut, whether it's a piece of cheese or a tablet or whatever, goes from your gut into your liver. And the liver is a factory. It breaks things down and it makes things. And in this context, it makes clotting factors. Now, the synthetic estrogen in the contraceptive pill is a really potent stimulant to making clotting factors. Natural HRT is a very small but statistically significant stimulant to making clotting factors. But taken through the skin, it has no impact on blood coagulation, on the production of clotting factors. So it's perfectly safe. And the progestogen, which is in a progesterone-only pill, doesn't have any impact on clotting factors. It's only the estrogen component.
Brilliant. Fantastic. Thank you. Oh, sorry, Deborah, you're on.
Thank you very much, Sally and Dr. Morton. I've just seen a comment saying really clear explanation, and I agree. I have to say, you opened my eyes in terms of what endometriosis is, and I can really understand now why it causes so many people so much pain and concern during the menopause transition around, well, what's right for me? Because you've probably been struggling with this for a very long time and really don't want to see it getting any worse. You know, ideally, some people I'm sure will be thinking, thank goodness for menopause if this means it's going to stop this pain. So thank you very much for explaining that so clearly for us. And of course, we'll send out this recording so people can watch it again and read up the transcript, and look forward to seeing you again soon. Thank you very much, Dr. Morton. And thanks you, Sally.
Deborah. Lovely to see you. Bye, Sally.
Bye.